I'm Karlene Lawrence. I am faculty at SUNY Downstate Health Sciences University in the Department of Geriatric Psychiatry. Today we're presenting polypharmacy in older adults, when, why, and how to deprescribe and use fewer medications. And I'm joined by Dr. Roitman.
My name is Janna Roitman. I'm faculty at LIU Pharmacy. And as Dr. Lawrence just said, we're going to be presenting polypharmacy.
So this presentation is part of one of the grants on our service. We have two grants. We have a federal grant, a HRSA grant, which is a Geriatric Workforce Enhancement Program grant, and we also have a grant from New York State. This presentation is part of the federal grant. The overall mission of the grant is leveraging the Health Resources and Services Administration, which is HRSA, Geriatric Workforce Enhancement, which is GWEP, to permanently and sustainably transform the healthcare workforce and community in Brooklyn, which is New York HRSA Region 2, to be age-friendly and dementia-friendly. The goal of the GWEP is to align with HRSA's GWEP to educate and train primary care, geriatric workforce, and other appropriate specialties to provide age-friendly and dementia-friendly care for older adults in integrated geriatrics and primary care site delivery systems. The 4 M's is a framework of our grants, of both grants. What matters to the patient, and it's not the chief complaint and or their caregivers, and we try to accommodate that and help them to achieve what matters to them. Medication reconciliation at every visit to decrease the incidences of polypharmacy and possibility of adverse medication events. We are geriatric psychiatry, so we screen at every visit for incidences or possibilities of mental health disorders, memory deficits, or changes in the person's personality. And mobility, we're trying to assist all of our patients and our caregivers to remain in their residences as long as possible, aging in place and out of skilled nursing facilities. I don't have any conflicts of interest.
Me neither.
This presentation is part of our self-learning module curriculum B, as you can see at polypharmacy in older adults. The learning objectives upon completion of this module, the learners or persons watching this presentation will be able to discuss how polypharmacy can be avoided in the older adult, recall polypharmacy's adverse effects, identify high-risk medications for the older adult, state a number of medications that indicate polypharmacy, and recall what is included in the polypharmacy definition.
So let's start talking about polypharmacy. Polypharmacy is defined as taking 5 or more medications daily as required. Any combination of the products, prescription, over-the-counter medication, or nutrition or herbal supplements. Polypharmacy is especially prevalent in older adults, often due to the presence of multiple comorbidities that require complex treatment. This situation may lead to the concurrent use of multiple medications to manage various health, as well as patients being prescribed more medications that they may need. The increased number of medications can significantly increase the risk of medication adherence issues, particularly in older patients who may have cognitive or physical impairment, as well as adverse medication reactions. Prescribing is absolutely necessary and refers as limiting or decreasing number of medications and reviewing medications profile.
So there's no question that polypharmacy is a major problem in older people. Drugs, as we get older, certainly make a big difference to people. We have a physiological decline. We peak somewhere around 30 years of age, and from then on, all our body systems go down at about 1% per year. So obviously, when we're around about 80, we give a drug that in a 30-year-old will do no harm, is quite likely to do harm in an older person.
For one thing, our organs work differently when we're over 65. So we may not need as high of a medication dose as we used to when we were younger. Another thing is we sometimes get a paradoxical effect or an opposite effect when we're using a medicine for one purpose and we get an opposite effect. So we see that a lot with things like Benadryl or allergy medicines, where somebody might take that and then get confused because it affects that person in such a way.
They experience different side effects, different interactions between the medicines, and typically are on too many medications, in my opinion at least. We really work on trying to get down the number because once you're on so many medicines, it really affects the way you think and the way you move. So I find that patients that are on more medicines tend to fall more, tend to get lightheaded and dizzy easier, and also their thinking tends to be a little bit slower.
Well, all drugs can interact with other drugs, and so it's a very common thing to see. A friend of mine, Stephen Fitzgerald in Australia, actually looked at studies that have been done and showed that when you're older, if you are on more than 5 drugs, the 6th drug will either make you better, it has about a 25% chance of doing that, that's wonderful, but it also has a 25% chance of making you worse. So we have to start choosing drugs as we keep on adding them very, very carefully. And then we have to reevaluate if we give a person an extra drug to make sure it's not doing harm rather than good.
Other things to consider are things that are great for a younger adult that can prevent problems, and we get aggressive with their medical treatments to prevent things like heart attacks or strokes down the line. As somebody gets older, those medicines aren't going to be as effective because you need to be on them for a really long period of time to get some benefit from them, and after a while, people have they've eked out all of the benefits from those medicines, and they really just don't need to be on them anymore, and the risks of them are a lot higher than the benefit.
So who are at risk? Older adults are defined as persons greater than or equal to the age of 65. Patients with multiple chronic diseases such as diabetes, heart failure, hypertension, or chronic obstructive pulmonary disease. Patients with cognitive impairment or dementia, individuals seeking multiple healthcare providers, increased risk of duplicate or conflicting prescriptions, patients with a history of medication non-adherence.